Hello everyone, guys and girls. My name is Dr. Omkar Sangita Dalipra, and today I'm here in the session of Sparks. I welcome you all back, and today we'll be discussing about some important miscellaneous drugs. Okay, these drugs are very much important in your examinations, but we tend to miss out them in our whole pharmacology syllabus. So please remember, I have just narrowed these down. These are some important basic drugs that you need to remember. Also, in cases of your clinical practice, you need to remember these drugs. So be attentive throughout the session, and let's begin the session without any further delay. Okay. So yes, the important topic that we have come across in many central board examinations is your gout. So please remember, gout have always been an important question that have come in your examinations either from pathology, medicine or pharmacology. Okay, so let's see what is gout. What is gout? So in gout, what happens? There is hyperuricemia, right? There is hyperuricemia, that is excessive accumulation of uric acid inside the body. And how this uric acid accumulation occurs? So please remember, what happens is generally the proteins or the purines which are a part of nucleotides, right? They are broken down. So these purines or proteins which are broken down by the xanthine oxidase enzyme. Important, the xanthine oxidase enzyme. Okay, it is a rate limiting enzyme, please remember, in the purine metabolism. So proteins or purines are metabolized by this xanthine oxidase enzyme to uric acid. Okay, and this uric acid which is produced in the body is insoluble. Okay, therefore it has to be excreted out of the body via kidneys. Okay, it is excreted out of the body via kidneys. But in birds, what happens? There is one more enzyme known as uricase enzyme, which can convert this uric acid into a water soluble form known as allantoin. Okay, but this is only seen in cases of birds, not in humans. Humans mein uric acid banta hai and that is excreted out of the body. I hope things are clear till here. Okay, so what happens in gout? Why this hyperuricemia is there? Okay, it is due to there is overproduction, excess of production of uric acid is occurring inside the body, or there is under excretion of uric acid occurring inside the body, right? So either the body is not able to excrete the uric acid out properly, or it is producing uric acid in excess amounts, right? So it can present as either an acute episode of gout, or the patient can present in a chronic for chronic management of gout. So what happens, what we do in cases of acute gout? If a patient presents to you, what happens to this uric acid? This excess of uric acid actually deposits. Okay, these excess of uric acid deposit in the form of crystals in your joints. Okay, this deposits in the form of crystals in your various joints. Okay, deposit inside the joints, the most common being your first MTP, that is your first metatarsophalangeal joint, that is your great toe. ठीक है, so great toe में it is the most common site for your uric acid deposition. So uric acid crystals deposit over here and they lead to pain and inflammation. So they cause pain and inflammation. Redness would be there, swelling would be there, there would be pain in these joints, right? So this is a classical case of gout which presents like this, usually in adult males. So acute gout में क्या होता है? So what are the drug of choice if a patient presents to you in emergency with an acute episode of gout, there is excessive pain? What is the drug of choice that you would prescribe to this patient? So please remember, the drug of choice in cases of acute gout is none other than NSAIDs. So please remember, non-steroidal anti-inflammatory drugs. So our primary aim is what? Primary aim is to relieve the pain or to give analgesia, to provide pain relief, right? So therefore the drug of choice for acute episodes of gout are NSAIDs. Okay, we can also use steroids, but the preferred choice would still remain NSAIDs. We can also use steroids. But if the patient still complains even after giving NSAIDs or using steroids that the patient is still complaining of pain, then we need to move on to a more good drug. Okay, a better drug that we have known as colchicine. Okay, the better drug that we have is known as colchicine. Please remember, colchicine is a very important drug that we have, and colchicine, please remember, it is the most effective drug in gout. Okay, colchicine is the most effective drug in gout, which is usually used in cases of acute severe episodes of gout, right? The side effects which are associated with colchicine that you need to remember, first one being myopathy, and second one, it causes severe diarrhea. So please remember, colchicine can cause myopathy or severe diarrhea. So what is the mechanism of action of colchicine? How does colchicine act? So it needs to inhibit inflammation somewhere, right? So it inhibits granulocyte migration. So what happens is it inhibits granulocyte migration or neutrophil migration, which can abort. If granulocytes or neutrophils are not migrated, there would be no inflammation. So this can abort the inflammation episode, right? So it inhibits granulocyte migration. It can inhibit the release of glycoprotein from neutrophils, or it can also inhibit the mitotic spindle in neutrophils. Okay, so please remember, this is the mechanism of action of colchicine, by which it aborts the action of inflammation which usually occurs in gout, right? Then talking about chronic gout. Chronic gout is usually divided as overproducers or under-excretors, like the people in which, or the patients in whom there is excess production of uric acid, or the patients in whom the uric acid is not able to excrete out properly. So in cases of overproducers, most of the patients of chronic gout are overproducers. Okay, most of the patients are overproducers. So the drug of choice for chronic gout if asked, or the drug of choice if only asked, or drug of choice for overproducers if asked, it would be which drug? It would be your drug known as allopurinol. The drug name is allopurinol, and the questions have been repetitively asked on this drug, allopurinol, important drug. What this allopurinol does? So please remember, allopurinol inhibits xanthine oxidase enzyme. So please remember, allopurinol is a drug which inhibits xanthine oxidase enzyme. Very important. The mechanism of action have been asked multiple times of allopurinol. Allopurinol is the drug of choice in chronic gout, and it inhibits xanthine oxidase. But some individuals are allergic to allopurinol. So in these cases, what can be done? Another drug can be used, and that is known as febuxostat, which also inhibits xanthine oxidase. Okay, the mechanism of action is same, but only in cases of allergic patients to allopurinol we can use febuxostat drug. Whereas in cases of under-excretors, okay, under-excretors, the kidney is not able to excrete the uric acid properly. Therefore, in cases of under-excretors, the drug of choice which is generally used is probenecid. Okay, please remember, the drug of choice is probenecid, which enhances the uric acid excretion out of the body. Okay, the other drugs which can be used are sulfenpyrazone or benzbromazone can be used. Okay, then lastly, what are the drugs which increase the uric acid metabolism? There can be some drugs which can increase this uric acid metabolism we have seen over here, okay, and can excrete the uric acid out of the body easily. So these drugs which increase the uric acid metabolism are two important drugs known as rasburicase. Important question have been asked in some of the examination central board. Okay, so rasburicase and pegloticase are the two important drugs which act by increasing the uric acid metabolism. Okay, both of these enzymes, okay, these are enzymes, right? A is at the end, so these are enzymes. So please remember, these are recombinant uricase enzymes. So please remember, pegloticase or rasburicase, these are two drugs which are recombinant uricase enzyme. And as we all know, uricase enzyme was present in birds which were converting uric acid which was insoluble to a soluble form known as allantoin, right? And which can be easily excreted out of the body by the kidneys, right? So therefore, rasburicase or pegloticase are the two important drugs which act by enhancing uric acid metabolism. These are recombinant uricases. Okay, these are recombinant uricases. What do we mean by peg? Peg means pegylated, and as we all know, wherever there is peg added, that is pegylated added, the drug would be longer acting, right? So please remember, these are the most important points that you need to remember about gout. Now moving further, guys, to our next one, and that is migraine. Okay, so what is migraine? Migraine is characterized by mainly what? Yes, migraine is characterized by headache. Okay, which type of headache? It is usually a unilateral headache. Okay, it is usually considered a one-day illness which just vanishes off in 24 hours, but it is disabling in character. That is, it does not let the patient or the individual work properly. Therefore, we need to treat it, right? And lastly, what is it? Is associated with nausea and vomiting. Also, there is photophobia. Okay, the patient gets frustrated with just hearing some sound or just by light. Okay, all these things. So this is the usual episode of migraine. Migraine comes in episodes. It is an episodic disease. So whenever migraine episodes come, we need to treat the patient, right? So now let's see what are the first of all the basic etiology or the basic pathophysiology of migraine. This is according to the recent advances, the recent studies which happened. There is some major inflammatory mediator, they say. Okay, there is some major inflammatory mediator which is responsible for causing vasodilatation and inflammation. So this major inflammatory mediator is known as Cgrp. So please remember, this major inflammatory mediator is known as Cgrp, that is calcitonin gene related peptide. Okay, this is known as calcitonin gene related peptide, and this major inflammatory mediator, it is released by the blood vessels of your brain. Okay, this is released by blood vessels of your brain, and it can lead to vasodilatation and inflammation. This major inflammatory mediator can cause vasodilatation and inflammation, leading to headache or migraine, right? So now, what is the drug of choice in cases of migraine? What is the drug of choice in cases of migraine? As always told you, in cases of acute episodes, the primary aim or the main aim to treat is to relieve the pain. Pain relief or analgesia is our main concern. So therefore, the drug of choice in acute episodes of migraine would be, or the drug of choice in migraine overall if asked, the answer should be what? Yes, the answer should be NSAIDs. So please remember, non-steroidal anti-inflammatory drugs are again the drug of choice in cases of acute migraine, right? Then talking about the next one, that is 5-HT1B or 1D receptors. Okay, usually these 5-HT1B or 1D receptors are located where? Yes, these 5-HT1B or 1D receptors are located in the blood vessels of brain. Okay, so these 5-HT1B or 1D receptors, if stimulated, okay, if stimulated, they can lead to vasoconstriction and they can decrease the inflammation also. Okay, stimulation of these 5-HT1B or 1D receptors can cause vasoconstriction and decrease inflammation. Okay, and which are the drugs which can act by stimulating these receptors? So please remember, the drugs which act by stimulating the 5-HT1B or 1D receptors are your triptans. Okay, the drugs are your triptans, and please remember, triptans are the drug of choice in cases of severe episodes of migraine. So please remember, mild to moderate migraine is treated by NSAIDs, but severe migraine के लिए drug of choice कौन सा है? It is your triptan drugs. Okay, important one, triptan drugs. And the next drug which also act by the same mechanism are ergot amines. Okay, ergot amines are derived by what? These are ergot alkaloids which are derived from a fungus known as Claviceps purpura. Question have been asked, ergot amines are derived by what? So please remember, ergot amines are derived from a fungus known as Claviceps purpura, but these ergot amines are more emetogenic. They can lead to more vomiting. Therefore, these drugs are usually not preferred. Okay. Then triptans are, as we all know, now we have seen, triptans will cause vasoconstriction. Therefore, there is a risk of vasospasm, and that is why these are contraindicated in cases of coronary artery disease. So if a patient is suffering from coronary artery or ischemic heart disease, triptans are usually contraindicated in those cases, right? Now, talking about the next drug of migraine, those are 5-HT One F Agonist. Okay, so 5-HT One F is a specific receptor which is only located or abundantly located in the fifth neuron, that is your trigeminal neurons. Okay, so trigeminal neurons are the most abundant site from which CGRP are released, and if we can block the or if we can just stimulate the fifth neuron, then it can help relieve migraine, right? So these fifth neuron or the trigeminal neuron which has these 5-HT1F receptors, okay, and if this 5-HT1F receptors are to be stimulated, then we can use some agonist. And which are the agonists used? So these drugs are known as ditans, and the drug name is lasmiditan. Okay, the drug name is lasmiditan. So please remember, guys, the drug which is 5-HT1F agonist is lasmiditan. Okay, lasmiditan. Next one, the next drug which are Cgrp antagonists, right? The main inflammatory mediator is what? Calcitonin gene related peptide, right? So we can just have some drugs which can act against the Cgrp. So the drugs which can act against the Cgrp, the first drug is Alcgepant. Okay, the first drug is Alcgepant, right? So gene related peptide antagonist. Okay, calcitonin gene related peptide antagonist, by the name itself you can remember. And there are also some monoclonal antibodies which act against this Cgrp. And which are the monoclonal antibodies? So remember the name, these are eltunumab and exenumab. So please remember the monoclonal antibodies which act against, okay, exenumab and eltunumab. Against the Cgrp are eltunumab and exenumab, right? Important one. Then next one, we need to remember some ABCs of migraine. Okay, the ABCs of migraine are important. Okay, where A goes for two drugs. First is an antidepressant like imipramine can be used. Okay, first is an antidepressant like imipramine. Second is an anti-epileptic drug like valproate, or you can also use topiramate. Okay, so please remember the two important drugs which are anti-epileptic also used in migraine are valproate or topiramate. Then B say B, there are two drugs. First are your beta blockers like propranolol, a non-selective beta blocker like propranolol. An important point about propranolol is it is the drug of choice for prophylaxis of migraine. So to prevent migraine, the drug of choice for prophylaxis is propranolol, which is a beta blocker, non-selective one. Okay, and the other one are your botulinum toxin. Botulinum toxin is also used for the same reason. Okay, it causes vasoconstriction, therefore botulinum toxin can be used. Then C say the next drugs are from C, and there is a very important drug with a calcium channel blocker, and this is known as flunarizine, which gives very good relief in cases of migraine. The drug name is flunarizine. Okay, the drug name is flunarizine, which is a calcium channel blocker. And the other drugs would be your Cgrp antagonists or Cgrp blockers that we have already studied, all Cgpant or monoclonal antibodies like eltanumab and exenumab. And lastly, from migraine you need to remember one single drug that is known as methylsergide. Okay, the drug known as methylsergide, right? With this we finish migraine. The drug of choice for acute episodes of migraine are NSAIDs. For mild to moderate cases, for severe cases, the drug of choice are triptans, which are 5-HT1B and 1D receptor stimulators, right? Important ones. And the drug of choice for prophylaxis of migraine are propranolol. Moving further, guys, to our next one, that is rheumatoid arthritis. Okay, so as we all know, rheumatoid arthritis is usually characterized by joint stiffness, okay, some deformities, inability to extend, inability to perform your daily activities, okay, joint swelling, there is some inflammation, pain, excessive pain, and there is a characteristic morning stiffness which usually lasts for more than 1 hour, right? So these are all the characteristics of rheumatoid arthritis, which usually affects adult females, right, more commonly. So now we'll study some drugs which are used in cases of rheumatoid arthritis. Again, now rheumatoid arthritis, if a patient presents to you in acute episode of pain, definitely for pain relief you can either use NSAIDs or steroids. So what is the basic function of NSAIDs or steroids in this? So steroids would decrease the pain and inflammation. So what is the function of NSAIDs or steroids? They will decrease the pain, they will cause pain relief, and they will relieve some inflammation, but they would not have any effect on disease progression. So please remember, they would have no effect on disease progression. Okay, disease is continuing as itself, it is only giving you pain relief. These have no effect on disease progression. And the last important point to be remembered is these are faster acting drugs. Okay, NSAIDs or steroids are faster acting drugs. Now talking about the next one, those are your DMARDs or SARDs. What are DMARDs? Disease modifying anti-rheumatoid drugs. What are DMARDs? Disease modifying anti-rheumatoid drugs. Important one. Whereas SARDs are slowly acting anti-rheumatoid drugs, right? So DMARDs are divided into conventional DMARDs. These are your conventional DMARDs, and some biological DMARDs, right? So which are the conventional DMARDs? Conventional DMARDs can be remembered by the name Chris, Gale, Picks, Major 6. Okay, so by Chris you can remember a drug known as Chloroquine, which we have studied earlier also in antimicrobials, antimalarial agent, right? Chloroquine. So please remember, Chloroquine is a DMARD of choice in cases of pregnancy. So please remember, DMARD of choice in cases of pregnancy is what? Chloroquine. As we have already studied, chloroquine is a very safe drug, therefore it is a DMARD of choice in cases of pregnancy. Next, G goes for gold salts, okay, gold or aurum salts. Then A goes for what? A goes for azathioprine. Azathioprine is a immunomodulator or an immunosuppressant drug. So please remember azathioprine. I goes for what? I goes for inhibitors of JAK-STAT pathway. Okay, so please remember inhibitors of JAK. The drug name is tofacitinib. Okay, the drug name are tofacitinib or baricitinib. Important drugs which are inhibitors of JAK. L goes for the another drug known as leflunomide. Okay, so N goes for another drug. L goes for leflunomide. Then PIX goes for which drug? PIX goes for penicillamine. Okay, PIX goes for penicillamine. M, major, important one. Which is the major drug? By this only you can remember. Which is the major drug used in DMARDs? So please remember, the major drug or the most common DMARD use or the drug of choice for rheumatoid arthritis in all other cases except pregnancy is this major drug known as Methotrexate. So please remember, the major drug in cases of rheumatoid arthritis is Methotrexate. So important, major se yaad rakh sakte ho. So it is Methotrexate. Okay, so as we all know, Methotrexate is also used as an anti-cancer drug in high doses, right? And Methotrexate acts by which mechanism? As we all know, Methotrexate inhibits folic acid synthesis, right? So methotrexate inhibits which enzyme? Yes, methotrexate inhibits this dihydrofolate reductase enzyme. We have also seen one antimicrobial agents like sulfonamides and trimethoprim, which also inhibits folic acid synthesis. So please remember, methotrexate also inhibits folic acid synthesis by inhibiting this dihydrofolate reductase enzyme. As we all know, methotrexate is a very important drug, and questions have been also asked on mechanism of action of methotrexate, right? So please remember this. So as it inhibits folic acid synthesis, the characteristic side effect which can be seen with this are megaloblastic anemia due to folic acid deficiency, and the second one being hepatotoxicity. Okay, it is a hepatotoxic drug, right? So please remember the two important side effects. As we all know, methotrexate is the most commonly used DMARD, and it was also the drug of choice in cases of rheumatoid arthritis. And what do we need to remember by 6? By 6, we remember a drug known as sulfasalazine. So as we all know, sulfasalazine is a drug of choice in cases of ulcerative colitis, right? And it is a DMARD of choice in cases of ankylosing spondylitis. Okay, important one. So, but the most common or the drug of choice always remains methotrexate, except in cases of pregnancy where it becomes chloroquine, right? Important. Now moving on to our biological DMARDs, and which are the important biological DMARDs. First are your TNF alpha inhibitors. Okay, so TNF, that is tumor necrosis factor alpha inhibitors. Okay, and these drugs that you need to remember, the TNF alpha inhibitors, are some monoclonal antibodies known as adalimumab. The drug name is adalimumab, certolizumab. Okay, certolizumab. The next one is important, that is infliximab, and the last one being etanercept. Okay, etanercept is very commonly used. So please remember, the most important drugs of TNF alpha inhibitors are adalimumab, certolizumab, infliximab, etanercept, and also golimumab. Okay, important ones. Out of these, all the other drugs are given by subcutaneous route. All the other drugs are given by subcutaneous route usually, except infliximab. I for infliximab, I for intravenous route. So please remember, infliximab is the only exception which is given by intravenous route. Okay. The next biological DMARD that we have is interleukin 1 receptor antagonist. Okay. So please remember, the drug which blocks the interleukin 1 receptor is none other than anakinra. So please remember, the drug name is anakinra. Question have been asked on anakinra usually. So please remember, interleukin 1 receptor antagonist usually acts as a biological DMARD, and the drug name is anakinra. And the last drug, interleukin 6 antagonist. Interleukin 6 antagonist, there are monoclonal antibodies known as tocilizumab. Okay, please remember, the monoclonal antibodies like tocilizumab or sarilumab. Please remember this. Okay. And as we all know, in COVID also we have used interleukin 6 antagonists like tocilizumab, right? Now next one, moving on to our next important topic in miscellaneous drugs, and that says emergency drugs. Okay, and these are the most important. I have explained you in various toxicities which are the drug of choice, okay, in various poisonings which are the drug of choice, but the point that we need to cover is the heavy metal poisoning. Okay, please remember, heavy metal poisoning is also a topic in cases of FMT, but people tend to forget this topic usually. So please remember, heavy metal poisoning is a very important topic, and for heavy metal poisoning, what can be used? We can use some chelating agents as the drug of choice. What are the chelating agents? Chelating agents actually form a complex with these metals, and then they excrete it out of the body, or they make it less harmful, right? So these are your chelating agents. Okay, so what are the chelating agents? Different chelating agents used in different kinds of metal poisoning. Let's see. Okay, first are your BAL. What is BAL? BAL is British anti-Lewisite. So please remember, what is BAL? BAL is British anti-Lewisite. Okay, it is also known as what? Yes, it is also known as dimercaprol. BAL or dimercaprol. And iske liye, it is used in cases of what? The mnemonic itself is BAL. Okay, so please remember, BAL is used in cases of BAL. It is used in cases of bismuth poisoning. It is used in cases of arsenic poisoning, and is used also in cases of lead poisoning. So please remember, BAL is used in cases of bismuth, arsenic and lead poisoning, but it is absolutely contraindicated. BAL kaha contraindicated ho sakta hai? BAL is usually contraindicated in cases of CAFE, right? So CAFE means cadmium poisoning and iron poisoning. So please remember, BAL is contraindicated in cases of cadmium and iron poisoning, right? Now next one is your EDTA, right? So now EDTA is the chelating agent which is used in cases of what? So please remember, EDTA is used in cases of manganese poisoning, iron poisoning, lead poisoning and cadmium poisoning. So thus you can remember by K. So the mnemonic becomes milk. So EDTA is usually used in cases of milk poisoning, right? So manganese, iron, lead and cadmium poisoning, right? Now moving on to our next one, guys, that says D-penicilamine. So D-penicilamine is an important chelating agent. Question was asked on D-penicilamine. So D-penicilamine is used generally in cases of what? It is used in cases of copper poisoning, as we all know. Okay, so please remember, D-penicilamine is used in cases of copper poisoning. And which is the copper excess condition? You all might be knowing. So copper excess condition is known as Wilson's disease, right? So therefore D-penicilamine is a drug which can be used in cases of Wilson's disease or in cases of copper poisoning. Last one are your iron chelators. Okay, last one are your iron chelators. So iron chelators are the specific drug used in cases of iron poisoning. Otherwise we can also use BAL or EDTA. But the better drugs which are there, these are these two drugs known as desferoxamine. Okay, remember, desferoxamine and deferriprone. Important two drugs which are used in cases of iron poisoning are desferoxamine and deferriprone, out of which desferoxamine is an injectable drug and injectables are faster acting. Therefore these are used in cases of acute iron poisoning. These are used in cases of acute iron poisoning. Whereas deferriprone, O comes in the name, therefore deferriprone is an oral drug which is used in cases of chronic iron overdose, right? Important ones to be remembered. Question have been asked on desferoxamine earlier as well. Next one are some important electrolyte disturbances. Okay, we usually tend to forget our electrolyte disturbances, guys, in pharma, but electrolyte disturbances have always remained an important point of patho, medicine and pharma as well, right? So please remember, these are the most important electrolyte disturbances and you need to treat it clinically also, right? In your clinical practice also, these would play a very important role because these comes as emergencies, electrolyte disturbances. So let's discuss about the most important ones. What are these? First is hyperkalemia, that is excess of calcium inside the body. And hyperkalemia, it can be either acute hyperkalemia or it can be either chronic hyperkalemia. So please remember, if there is acute hyperkalemia, on ECG you can see tall tended T waves. So this acute hyperkalemia can land up the patient into arrest, diastolic arrest. Therefore you need to treat it with a drug, and the drug of choice for acute hyperkalemia is IV calcium gluconate. So please remember, the drug of choice for acute hyperkalemia is IV calcium gluconate followed by IV insulin. Okay, regular insulin is usually used, IV regular insulin followed by IV salbutamol. Okay, so any of these drugs can be used, but the preferred or the drug of choice is IV calcium gluconate. Okay, and one more question has been asked, that insulin acts by which mechanism in cases of hyperkalemia? So please remember, insulin sends the potassium inside the cell, decreasing the blood potassium levels. Okay, insulin sends potassium inside the cell, the same way salbutamol also acts, right? And this way insulin acts in cases of hyperkalemia, but the drug of choice in cases of acute hyperkalemia is IV calcium gluconate. And in cases of chronic hyperkalemia, we can prefer an oral drug known as patiromer. Okay, the drug name is patiromer. Okay, oral drug. Whereas in cases of hypokalemia now, okay, I don't have space, so I am writing it over here above. So please remember, in cases of hypokalemia, when the potassium levels are decreased, definitely we'll go give potassium from outside. So please remember, the drug of choice in cases of hypokalemia is a potassium chloride drip or a KCl drip, right? Easy. Now next one is your hypercalcemia, when there is excess of calcium in the body, and now hypercalcemia can land up the patient into systolic arrest, right? So in hypercalcemia, the drug of choice is IV ibandronate. So please remember, a bisphosphonate known as IV ibandronate is a drug of choice in cases of acute hypercalcemia. Important to be remembered. Whereas in cases of hypocalcemia, when the calcium levels are decreased, definitely we'll give calcium from outside, that is IV calcium gluconate. So IV calcium gluconate is a drug of choice in acute hyperkalemia also and in hypocalcemia also, right? And lastly, the important one is your hypernatremia, that is excess of sodium inside the body. So in cases of hypernatremia, the drug which is preferred is 5% dextrose. So please remember, when the sodium level falls below 125 milliequivalents per liter, the drug of choice which is preferred is 5% dextrose. Whereas in cases of hyponatremia, when the sodium levels are decreased, okay, so please remember, in hypernatremia the sodium levels are more than 158 milliequivalents per liter, and therefore we use 5% dextrose. Whereas in cases of hyponatremia, the sodium levels are less than 125 milliequivalents per liter, and in cases of hyponatremia, the drug of choice is used as what? We use a 3% saline. Okay, so please remember, hypertonic saline or 3% saline is usually used to treat hyponatremia. Hyponatremia is usually treated accordingly based on the condition it has. Either it is euvolemic, hypovolemic, or hypervolemic hyponatremia. Based on that, there is different management, but the basic management is 3% saline or hypertonic saline. Okay, so with this we come to the end of this session. This was a really short session covering all the important miscellaneous drugs which are not covered anywhere else. Gout and migraine drugs are also covered in orthocoids, but we tend to forget those over there. So I have specially covered them in the separate session because you need to remember about these drugs at any cost. Okay, now we'll just solve some questions before ending this session, and there are two questions. The first question says, a patient presented with complaints of rice watery diarrhea and hyperpigmented patches on the palms. You suspect a metal poisoning. Which is the preferred chelating agent used in this condition? Okay, so let's come to a provisional diagnosis. Which metal poisoning is this? Okay, they have spoke about rice watery diarrhea. Okay, so rice watery diarrhea resembling cholera. So which of the metal poisoning resembles cholera? If you study FMT, you will get to know one of the metal poisoning resembles cholera, and also in that poisoning we can see hyperpigmented patches on the palms, and these hyperpigmented patches, blackish patches on the palms, are known as raindrop pigmentation. So please remember these two important points, that a poisoning resembling cholera with rice watery diarrhea and raindrop pigmentation, this is nothing else but your arsenic poisoning. Okay, this is nothing but your arsenic poisoning. And which is the preferred drug or the chelating agent used in cases of arsenic poisoning? As we all know, it is your option A, BAL, that is British anti-revacite, where A goes for arsenic poisoning in the name itself, right? So please remember this. D-penicillamine for your copper poisoning, right? And desferoxamine for your iron poisoning. Next, you're a 45-year-old male, important, a 45-year-old male came with complaints of joint pain and swelling. The great toe is extremely red, swollen and tender. Okay, joint aspiration performed shows negative birefringent needle-shaped crystals. The drug given for management in this condition inhibits which enzyme? And the options are HGPRT, dihydrofolate reductase, xanthine oxidase and neutral endopeptidase. So please remember guys, let's come to a provisional diagnosis again. 45-year-old male, right? It is an adult male, usually in the middle age. Joint pain and swelling is there, good. Grade 2 is extremely rare. That is the most common site affected is your first metatarsophalangeal joint, that is your grade 2, right? We have come to a diagnosis already, but let's see. Okay, joint aspiration shows negative birefringent needle-shaped crystals. Yes, in synovium usually negative birefringent needle-shaped crystals are usually deposited in cases of gout. Yes, and the provisional diagnosis over here is gout. Now there is some drug which is given in the management of this condition, and this drug inhibits which enzyme? Okay, and as we all know, the drug of choice used in cases of gout is allopurinol, and allopurinol inhibits which enzyme? Yes, allopurinol inhibits option C, xanthine oxidase enzyme, right? So I hope now all of you have understood these things, and with this we come to the end of this session, and thank you so much for attending this session, and we will soon meet in another session of Sparks. Thank you so much.